I'm going to be doing as many questions as I can in the next 20 minutes, trying to get as many correct as possible while explaining my thought process, and I want you to try along with me and see how you do. Thanks again to TrueLearn for granting me access to their question bank for this video. There is a $25 coupon code for any subscription over 90 days, so if you're interested, definitely check them out. And why don't we get started? A 28-year-old female presents to the clinic for routine follow-up. Which of the following is the most definitive treatment of the underlying cause of the patient's presentation? Aortic valve repair, furosemide, pulmonary valve repair, right heart catheterization, or tadalafil? So let's see what's going on. She has a history of Tetralogy of Fallot repaired in childhood. She's become progressively more short of breath, and she's quite tachycardic. Her respiratory rate is 24, and there is a parasternal impulse at the left sternal border. So that is telling me that basically, I think that's RV overload, which is causing that. Whereas with LV overload, I would think it more at the apex, have a PMI over there. Additionally, there is a soft systolic murmur at the second left intercostal space and a decrescendo diastolic murmur at the left sternal border. So any of the murmurs that increase with inspiration immediately make me think of right-sided valvular pathologies, because basically when you take an inspiration, you are increasing preload to the right side of your heart. It's kind of like you're generating some negative pressure that allows more blood to come back. So a diastolic murmur at the left sternal border would be consistent with tricuspid regurg. And then a soft systolic murmur at the second left intercostal space would be consistent with a pulmonic valve stenosis. So the most definitive treatment of the underlying cause of her presentation, I would say that probably the pulmonic stenosis is kind of, causing the most symptoms here. So this would be the most definitive treatment. Furosemide would just be kind of temporary. Right heart cardiac cath would just be kind of diagnostic. Tadalafil would basically decrease preload to the right side of the heart, I believe. Aortic valve, I don't think is an issue here. But the most definitive treatment would be pulmonary valve repair. And I'm going to go with that answer, and that is the correct answer. All right, next question. A 69-year-old man presents to oncology clinic for follow-up of treated prostate cancer. His prostate cancer was treated 2 years ago with prostatectomy with subsequent undetectable PSA levels. He has hypertension and nephrolithiasis, and he's on amlodipine and aspirin. His phosphorus is a little on the low side. His albumin's normal. His calcium is up, and his parathyroid is also up. So that's abnormal. Your parathyroid, if you go back to the hypercalcemia video, should not be normal if your calcium is elevated, right? Your PTH should be suppressed in that case. And so we are actually having some abnormal function of his parathyroid hormone right here. His PSA is still undetectable. His hydroxyvitamin D is normal. SPEP is normal. PTHRP is normal. Calcitriol is elevated. So immediately I'm kind of thinking primary hyperparathyroidism as a cause here, because that would be one cause of why your PTH is still normal, even though you have a calcium that's elevated. And I think maybe the prostate cancer and things like that may just be kind of a red herring. So demonstrates the presence of hypercalcemia since at least 3 years prior. So that kind of makes sense because his prostate cancer was 2 years ago. So if it was related to the prostate cancer, we wouldn't have seen this hypercalcemia 3 years prior. It's likely that he had some hyperparathyroidism going on at that time as well. And so the next step in evaluation, we don't evaluate with calcitonin. We already did an SPEP, so it's less likely multiple myeloma. So no need for the free kappa lambda chain. CT scan, chest, abdomen, pelvis is just looking for like general malignancy. Skeletal survey is again going to be looking for multiple myeloma. So I'm going to be looking for a PTH kind of adenoma here, a parathyroid adenoma. And this is consistent with primary hyperparathyroidism. So you can see this was a very difficult one for a lot of people, but it all comes down to understanding that this normal parathyroid hormone level is actually not normal in the case of your calcium being elevated. You should see it, undetectable or low, basically, is what the parathyroid should normally be doing. So that's how you reason through this case. All right, let's move on to the next question. A 25-year-old presents to the emergency department with a 30-minute history of facial numbness and weakness. Immediately, facial numbness and weakness is kind of giving me stroke vibes, but it's a 25-year-old, so they don't fit the kind of classic demographic. However, now it's saying he was having dinner at a Japanese restaurant and noticed symptoms 15 minutes into eating one of the dishes. So now I'm thinking of some kind of anaphylactic reaction or allergic reaction. His friends also had similar symptoms. Denies chest pain, abdominal discomfort, nausea, vomiting, diarrhea. So one of the things that you can get, I believe, is from tuna. I think they have this weird histamine reaction or tetrodotoxin or something that's in there. And actually, okay, so shoot, it's actually one of these two. It's ciguatoxin or tetrodotoxin from the tuna at the Japanese restaurant. This is like a kind of classic board review question. It's always like the tuna at the Japanese restaurant. So he's an uncomfortable looking male. His oropharynx is clear of edema. Lungs are clear bilaterally. Muscle strength is 2 out of 5 in the upper and lower extremities bilaterally. And reflexes are 1+ at the triceps, brachioradialis, patella, and Achilles bilaterally. So I hate this one because I always get it mixed up between tetrodotoxin and ciguatoxin. For some reason, the first thing that came to my mind was tetrodotoxin, so maybe it's more common. The ciguatoxin is definitely the other one. Arsenic and saxitoxin. I've never heard of saxitoxin, so we're gonna go with tetrodotoxin, and we are correct. And it was from pufferfish poisoning, so I actually remembered the organism wrong, but it was tetrodotoxin. Ciguatoxin, you can see a lot of other people guess that one, but it looks like that is from dinoflagellate Gambierdiscus toxicus, responsible for ciguatera poisoning via activation of the voltage-gated sodium channel. Causes similar symptoms with gastrointestinal, cardiac, and neurologic symptoms. Typically, GI symptoms precede the cardiac symptoms and neurologic symptoms with complete heart block. Temperature dysthesias are also a hallmark of ciguatera poisoning. Okay, so going back to my Anki cards real quick. So histamine is in the spoiled dark meat fish like tuna, and it's going to be causing like an anaphylactic type reaction. Pufferfish is the tetrodotoxin, which causes the paresthesias and weakness. Ciguatoxin is going to be with reef fish such as barracuda, snapper, and moray eel, causing the GI symptoms, and then the temperature dissociations, bradycardia, heart block, and hypotension. All right, maybe I'll remember this a little bit better now. And I think that's the second question I got right. So, we're 3 for 0 now. Okay, I haven't been keeping the score updated, so let's update that real quick. 3 for 0. A 50-year-old man presents to clinic to establish care. A review of medical records shows that the patient was diagnosed with an autosomal dominant condition when he was 20 years old, which was associated with ocular problems. So immediately I'm thinking about myasthenia gravis because I think myasthenia gravis may be autosomal dominant. The patient also had a type B aortic dissection when he was 40 years old, which was treated medically. He complains of chronic dyspnea and chest pain despite treatment of aspirin, digoxin, and furosemide. He has a mid-systolic click followed by a mid to late systolic murmur, increasing intensity with standing and Valsalva, best heard at the apex. So best heard at the apex makes me think of mitral valve. He has a mid-systolic click, which makes me think of mitral valve prolapse. And then a mid to late systolic murmur, that would be mitral regurg because of the positioning at the apex. It's increasing in intensity with standing. So it's actually hokum. Yeah, this is just hokum because with standing and Valsalva, you're decreasing preload, and that's going to worsen the murmur of your hokum because your basically hokum gets better when you have more preload. It helps expand the ventricle and the ventricular chamber more, so you have less obstruction. So this is definitely hypertrophic cardiomyopathy. Although I'm trying to link up why he had type B aortic dissection, because that could definitely line up with Marfan syndrome as well. And then Marfan syndrome potentially could have kind of mitral valve prolapse symptoms as well. I'm going to take out osteogenesis imperfecta because that is basically failure of your bones to form properly. So it'd be kind of recurrent fractures and things like that. And then Ehlers-Danlos actually is very similar to Marfan syndrome, at least my understanding of some of the consequences that it could have. Marfan syndrome and Ehlers-Danlos, Marfan, they'll have kind of the Marfanoid body habitus, very tall, very long arms. Ehlers-Danlos, they're going to have that joint hypermobility and the skin hypermobility. So we're not really getting any of that, but we are getting ocular problems, which I do believe is more of a Marfan syndrome rather than an Ehlers-Danlos syndrome. So actually, I don't think it's hokum because I think this is probably just really bad mitral valve prolapse that has a mitral regurg murmur. Because if this was hokum, we would expect to see the murmur at the right upper sternal border. And so Marfan syndrome definitely has eye problems. Ehlers-Danlos, I'm not sure as much. So Marfan also has aortic, connective tissue issues, mitral valve prolapse predilection. So I'm going to go with Marfan syndrome, but this is a kind of tough one. I'm not sure about this one. And we are correct. So actually 79% of people got this one correct. I'm actually pretty impressed. So cardiac conditions frequently associated with Marfan syndrome include aortic dissection and mitral valve prolapse. It's also associated with ectopia lentis, and also has the joint laxity as well. So mitral valve prolapse has that mid-systolic click and a subsequent systolic murmur that increases in intensity with decreased preload. So yeah, I conflated that. I forgot about the location briefly, so I was thinking about HOCM, but mitral valve prolapse also gets worse with decreased preload. So Ehlers-Danlos has a minimal excess risk of mitral valve prolapse, and ocular problems are less likely in Ehlers-Danlos syndrome. All right, that's 4 for 0. Let's move up. A 22-year-old man presents to the emergency department with altered mental status. The police officers report that he was apprehended walking in hot weather in the Arizona desert, cannot obtain history due to his altered mental status. His temperature is 104.9. Which of the following is the most appropriate next step in management? Tylenol? No, because Tylenol is useful for people who have fever, whereas hyperthermia is actually just... So fever is actually an increase in the temperature regulation set point of your body, which can happen in signs of infection because your body is trying to fight off the infection. Whereas hyperthermia is actually just an environmental increase in the temperature, causing your temperature to be elevated. It has nothing to do with the temperature set point that your brain has set. And so Tylenol would be completely ineffective here. Hemodialysis here, if there is some kind of drug that they reveal here, then, we can consider that. But normal saline, one of the things I'm thinking is there any cooling solution? Typically, I don't think about cold normal saline. Normally, I think about warming normal saline for people who are hypothermic. And then platelet transfusion. So actually, maybe I should take off acetaminophen for now. Let's read the question stem a little bit more to figure out what's going on. Physical exam reveals a male who is incoherent, opens his eyes and grimaces to pain. Pupils are dilated, reacts sluggishly to light. All of this seems kind of non-specific to me so far. Maybe there's some clues hidden in there, but his heart is tachycardic without murmurs. Abdomen is soft. His lungs are clear. Skin is pink and dry. So his white count is 18.5. Also, just kind of non-specific to me. He's very ill right now, so it's kind of like this stress response. His platelets are 62. That is quite low. That is definitely sticking out to me right now. Sodium 149 goes with his dehydration. His potassium 6.1 also could be attributed to dehydration, as well as the creatinine being up. His AST and ALT are both up. His CK is massively elevated, 92,000. So that is definitely accounting for some of the AST that we are seeing. So CK elevations can cause elevation in your AST. And then his fibrinogen is a little low. His fibrinogen split products are normal. So I think that's basically telling us that he's not in DIC or something like that. Dipstick shows reddish brown urine, 1+ blood, urine myoglobin of 750, specific gravity of less than 1.005, and trace protein and ketones. Specific gravity of less than 1.005. So he's super dilute with his urine. I would have expected him to be potentially super concentrated, because if he's so dehydrated, I would expect his urine to be trying to hold on to everything. So it's a little weird why he has such a low specific gravity. Urine drug screen and cultures are negative. CT scan is normal. He receives external cooling using cooling blankets, and his mental status improves. So is this just like a really bad heat stroke potentially? The rhabdo is quite impressive. I don't think he has any indication for platelet transfusion at 60,000. It is definitely low, but maybe it's like some really severe acute response. And so normal saline, he does seem very dehydrated. I feel like for the rhabdo, we need to give him normal saline. It doesn't give us anything saying that he needs dialysis right now. And then Tylenol, again, I don't think is going to be helpful. So there may be something that I'm missing here, because is the answer just treating with saline? I mean, I would want to see if saline helps with his CK and with his hyperkalemia and his AKI. Just seems like he's really dehydrated. So I'm just going to start with normal saline, and that is the correct answer. So it's basically just a question of rhabdo. So I think I was kind of overcomplicating it over a little bit, but that was some pretty severe rhabdo to have your platelets down in the 60s and your AST, ALT that elevated. Definitely very impressive rhabdo. Yeah, and this was basically just a heat stroke, but basically it was showing that heat stroke could be complicated by rhabdo, DIC, renal dysfunction, and electrolyte abnormalities. So really it is possible to get all of these potential side effects. All right, that's 5 for 0. Let's keep it up. A 70-year-old man presents to the emergency department with a 5-day history of dyspnea, palpitations, and fatigue. He has no medical conditions and takes no medications. He does not consume alcohol, illicit substances, or tobacco. Which of the following is the most appropriate next course of action? Taking a look at his EKG, I am trying to see if there's anything standing. It looks regular to me. The rate is about 100, so he's a little bit tachycardic. Axis, kind of hard to tell, but it looks normal. And then any ST changes or morphology changes, nothing super standing out to me right now, except his P waves in lead 2 are downward facing. So that sort of makes me think about an ectopic atrial pacemaker, potentially. Normally we should see the P wave upright in lead 2. So this is potentially telling us that there is another source of atrial activity that's going on. And I'm looking at the PR interval, and it looks pretty steady all throughout. His T wave is kind of interesting. It's kind of like got this biphasic appearance like this, kind of making me wonder if there's a P wave buried in there, but I wouldn't really know what to make of that with tachycardia. If somebody had a P wave marching through with no QRSs, I'd be thinking of complete heart block, but they would have very, very low heart rate instead. So let's see. Administer intravenous ibutylide in the ED for acute arrhythmia termination. I doubt that. It's one of those weird antiarrhythmics that I've never seen used. So let's skip that one. Admit the patient and start heparin drip, start a diltiazem drip, and TEE reveals no atrial thrombi, attempt cardioversion. So that would be an answer for AFib, but we are seeing discrete atrial activity with these P waves, so I don't think this is AFib. Start heparin, diltiazem drip, perform an AFib ablation the following day. He doesn't have AFib though, is the problem. Discharge the patient with a prescription for a beta blocker and warfarin. Perform an electrical cardioversion right away, and then start a heparin drip and admit the patient. So maybe he does have AFib. I mean, they're basically all making it sound like it's AFib. It doesn't look like AFib to me though. Maybe let's read the rest of the question. So his heart rate is 148. He appears uncomfortable. He's tachycardic with an irregular rhythm. Oh, they're calling this irregular? This looks pretty regular to me. Maybe my eyes are just tricking me, or maybe they just uploaded the wrong EKG here. So let's see. TEE shows that he has moderate mitral stenosis, does not have elevated right-sided pressures. So let me just assume that this patient has AFib. And am I just crazy? I just don't think this is AFib. It doesn't look like classic AFib to me. I would be expecting a much more fibrillating baseline. But anyways, let's take a look. I think this is the wrong EKG because it's also not 150 beats per minute. This is 1, 2, 3, 2.5. So it's like 125 maybe. So how would we treat AFib? So we would only do electrical cardioversion right away if he was unstable. Doesn't sound like he is unstable. He is symptomatic though. And so for this one, like warfarin, we're not going to use warfarin. So old school. Prescription for beta blocker. He's acutely symptomatic right now. We need to do something more immediately. And then let's see. Yeah, the most standard would be admit him, start a heparin drip, start a diltiazem drip. We wouldn't even start a heparin drip. You could potentially just start him on a DOAC. And then because he's symptomatic, you could do TEE cardioversion. So basically you're taking a look to make sure there's no thrombi there that would, potentially shoot off if you cardioverted this patient. And then if it looks clear, then you can cardiovert them. And then this one, atrial fibrillation ablation is just not going to happen the next day. That's not logistically feasible. So yeah, the correct answer is B, admit the patient, start them on anticoagulation, and do TEE cardioversion the next day. Okay, so they're calling this a flutter. I don't really see flutter waves still, but maybe there are flutter waves. I'm not 100% sure. So anyways, we got the question right. So let's move on to the next one. Question number 7. We're on a roll right now, you guys. So a 21-year-old man presents to the emergency department with a 3-day history of sore throat and difficulty swallowing. So immediately think about strep throat, potential viral pharyngitis. He has left maxillary sinus pain. over-the-counter decongestants, and lozenges with no improvement. He has a history of type 1 diabetes for which he's being treated with basal bolus therapy. And I actually just did a doctoral on this recently. I am very concerned about mucormycosis whenever I hear this constellation. If somebody has diabetes, they've got sinus pain, they've got, all these scary symptoms going on, immediately I want to make sure it's not mucor. So let's see if there's anything else that's, kind of pointing to that. But otherwise, viral rhinosinusitis is probably the most common thing that could be going on. They're probably trying to scare us with this type 1 diabetes, but if we're just going off most common, it'd probably be a viral thing. Nasopharyngeal lymphoma would be like an Asian person, most likely. And I believe they're quite rapidly developing. Lemire syndrome is going to be an IJV thrombus after having kind of a pharyngitis picture, especially with Fusobacterium necrophorum. And allergic rhinitis, he's definitely not having allergic rhinitis. That would just be a runny nose. It would not be so painful like this. So his vital signs, he's febrile to 100.5, blood pressure 102/68. His heart rate is 109, and his O2 sat is 93%. There are necrotic lesions within the neph layers. Oh man, this is not looking good. Tenderness to palpation of the maxillary sinus, oropharynx erythematous with dark drainage at the left side. Neck veins are non-distended or palpable, so that makes Lemire syndrome less likely because you would see distended neck veins with the IJ thrombus. Nasopharyngeal lymphoma, I don't see any reason. Viral sinusitis, the most if we were to go over the most likely, viral is the most likely, but as soon as you add in the necrotic lesions, that's just scary, man. This is mucormycosis. 93% of people got this. Mucormycosis presents with necrotic eschars and sinus pain in patients with risk factors such as immunosuppression, iron chelator use, I actually didn't know that, or type 1 diabetes. Treatment includes debridement and antifungals, and actually not just type 1 diabetes, it can be type 2 as well. I saw it in a type 2 diabetes patient. So that is another correct answer. Hopefully that patient does well, and let's move on to the next one. A 58-year-old male with a past medical history of type 2 diabetes, hypertension, and Crohn's disease, status post small bowel resection, is brought to the office by her daughter for evaluation of recurrent fall and memory loss. Okay, so he had a resection, now he's having recurrent falls and memory loss. Immediately what I'm thinking is vitamin deficiencies. And you can already look into all of the answer choices. There's just so many vitamin deficiencies that they're already listing. And immediately out of these ones, I would think about B12 deficiency because that can cause subacute decombined degeneration, can cause peripheral neuropathy and kind of these neurologic and sensory deficits and things like that. And so we know that after a bowel resection, especially the small bowel, you're going to be losing some reabsorption of critical nutrients. So small bowel, you think about iron fist, bro, is the order in which they are absorbed. So iron is absorbed in the duodenum, folate is absorbed in the jejunum, and B12 is absorbed in the ileum. And a lot of times Crohn's disease is predominantly targeting the ileum because the ileum is very highly immunogenetically active. And so a lot of autoimmune diseases and infections, they love to go to the terminal ileum. So this is probably where they removed. And so it's exposing him to a risk of being B12 deficient. So, yep, he's been more irritable and forgetful. No hearing or visual issues, but he does have diminished vibration sense, very much in line with B12 deficiency, hyperreflexia, and mild sensory loss in the toes. Romberg sign is positive. This is 100% B12 deficiency, and that is the correct answer. Let's keep up the streak, you guys. We are going up onto 8 now, and can we get even higher? This may be the best run we've had yet. At some point, I'm going to jinx it at some point, but we'll see how we do. A 65-year-old female presents to the emergency department with 1 week of fever, chills, and dysuria. Which of the following is the most appropriate next step in management? Check her serum IgE levels, continue meropenem, discontinue all antibiotics, redraw blood cultures, or switch her antibiotics to ceftriaxone. So she's coming in with a UTI. She's hypotensive, tachycardic, and febrile. She's pretty sick. Blood and urine cultures are drawn. She's resuscitated with IV fluids, started on vancomycin and meropenem. I'm surprised they started so broad just from the get-go, but maybe if she was like an ICU patient and just super sick, that's why they would have done that. But even still, I think ID stewardship would have something to say about starting her on meropenem right away, unless she had a history of ESBL organisms or things like that. She improves clinically. 2 days later, she grows E. coli sensitive to ceftriaxone. She has documented allergy to penicillin. When questioned, she does not recall the allergic reaction as this occurred when she was a young child. Penicillin skin testing is not immediately available. So most penicillin allergies are not true allergies. When people say that they have allergies, they really are not. A lot of times kids get little rashes and things like that in exposure to antibiotics, and then people tag it as a penicillin allergy. But in general, unless it's a very clear history of it, you really don't have to worry about penicillin allergy unless they're saying they had like a clear anaphylactic event. In this case, she doesn't recall the allergic reaction. She only had it as a young kid. She hasn't had any other episodes of this. I feel pretty confident that we could, go and pursue with the beta-lactam, especially with ceftriaxone, which is not like third generation or whatever. Basically it's like a later penicillin also. So it has less cross-reactivity with causing penicillin allergies as well. Redrawing blood cultures would not be helpful. She still needs more treatment. It's only been 2 days. No need to continue such broad treatment with meropenem, and then IgE levels. Basically, it's in most cases, penicillin allergies should be questioned. They are usually not true allergies unless it was like an anaphylactic event. And so the answer is going to be switching antibiotics to ceftriaxone. And yeah, most patients were inappropriately labeled or their allergy resolved over time. Even among patients with true penicillin allergy, 97% will tolerate cephalosporins. So that is question number 9, and we're just going to keep going. I mean, I'm like, should I just stop at some point and just end on a good note, or just keep going to see how long we can stretch this streak? I'm thinking about going for the latter. So some more explanation. So more than 90% of patients who report a penicillin allergy do not have an IgE-mediated sensitivity when skin testing is performed. They were either inappropriately labeled or had a prior allergy that resolved with time. To determine if a patient with recorded allergy can safely receive cephalosporin, penicillin skin testing is encouraged. However, if it's not available, the clinician must estimate the risk of a serious IgE-mediated reaction to cephalosporin by attaining clinical history and timing since reported allergic reaction. Studies show that 90 to 99% of all patients reporting a penicillin allergy will tolerate a cephalosporin. Mild reactions to penicillin without hives, angioedema, anaphylaxis can be deemed as having minimal risk for serious reactions to beta-lactam. Patients are also low risk if their record lists the allergy, but they do not recall having a reaction. All right, let's move on to the next question. A 54-year-old man presents with 6 months of fatigue, lower extremity pain and swelling, and heart racing. His medical history is notable for hypertension, morbid obesity, now with normal weight following Roux-en-Y gastric bypass, and a very low carbohydrate diet. So again, we've got another patient with a bowel resection. And so again, at high risk for nutrient deficiencies. And one of the things that I'm thinking about right off the bat with his heart racing and lower extremity pain and swelling is kind of like a wet berry or dry berry. I forget which one it is, but I probably wet berry because he's got this lower extremity pain and swelling. But if you have a deficiency in certain nutrients, you can get berry, which is like a high output heart failure. And I believe it's going to be a thiamine deficiency that's going to cause berry. So let's take a look. He had untreated sleep apnea for 25 years. He's on lisinopril and furosemide and atorvastatin. His heart rate's 110. He has a displaced apical impulse, so he's volume overloaded. Bilateral crackles, 2+ edema to the knees. He has decreased sensation to the mid-shin bilaterally, decreased strength at the ankles bilaterally. So can thiamine deficiency cause that? Yeah, I think so. Can B12 cause that? Yeah, but I don't think B12 necessarily, at least from what I know, causes like a berry kind of picture. His labs, everything looks pretty normal, but his lactic acid is high. So definitely thiamine deficiency can cause an lactic acidosis and elevated pyruvate. So even more signs for a thiamine deficiency. He has 4-chamber dilation. So this is kind of classic. It's a non-ischemic cardiomyopathy where you've got like a dilated cardiomyopathy from berry. And so this is going to be thiamine deficiency. 61% of people got this. Quite a few people picked vitamin B12, which would have been the second answer I would have gone for just because of those sensory deficits and his history of a bypass. But all the other things, the high output heart failure, the lactic acidosis, all of that points to thiamine. So it can cause wet berry with heart failure, cardiomegaly, peripheral neuropathy with sensory and motor components, possible Wernicke-Korsakoff, and elevated lactate and pyruvate. Now we are 10-0, you guys. Let's keep on trudging forward. I was going to end this video earlier, but we're just keeping on going. So a 45-year-old man presents to your clinic with dyspnea, chest pain, and weakness for 6 months. Which of the following is the most likely diagnosis? He's got bilateral patchy opacities on his chest x-ray. Allergic bronchopulmonary aspergillosis, I would be looking for elevated IgE. I'd be looking for a halo sign. Chronic eosinophilic pneumonia, I'd be looking for anti-seizure medications. I'd be looking for daptomycin, elevated eosinophils on his peripheral blood smear. Corticosteroid-induced myopathy, I'd be looking for history of steroid use, weakness, and then also elevated CK levels. EGPA, I'd be looking for possible neuropathy, possible history of sinusitis, allergies, eczema, atopy, and then polyangiitis with granulomatosis. I think they mean granulomatosis with polyangiitis. GPA, again, I'd be looking for sinus issues, would not be seeing the eosinophils. And then, yeah, they can be kind of similar to EGPA. So we'll have to kind of parse that out. So let's take a look. So just looking at his labs first, he's got 40% eosinophils. So immediately I'm already thinking chronic eosinophilic pneumonia, EGPA are kind of the top two. So why don't we just knock these out? Aspergillosis actually might still be on there with elevated eosinophils. Corticosteroids, if you're on steroids, you should actually have low peripheral eosinophils because it kind of suppresses them. Creatinine's normal. His IgE is elevated. His anti-myeloperoxidase antibody. So this is going to be a tough one, you guys. This might be the one that gets us. Anti-myeloperoxidase antibodies are positive. So those are the MPO antibodies, which I believe are present in about 50% of patients with EGPA. It's not reliable because it's only present 50% of the time, but MPO antibodies in EGPA. And then GPA would have the C-ANCA antibodies or the, what's it called? The, oh man, I'm blanking on the name. MPO and PR3, the PR3 antibodies, yeah. So, but the problem is he also has aspergillosis, which I believe could also cause a lot of other things to be positive. Like Coxy, definitely I've seen this with Coxy a bunch, where Coxy is just going to cause a bunch of random autoimmune things to become positive. So it doesn't mean that you have EGPA or vasculitis or something like that. It's literally just the Coxy itself causing it. So I don't know as much if aspergillosis can do something similar, but really this is coming down, I think at this point, to EGPA and ABPA. So with ABPA, I'm going to be looking for that classic history of asthma, recurrent kind of asthma exacerbations, maybe some kind of immunosuppression. EGPA, again, I'm going to be looking for those neuropathy symptoms, sinusitis. So let's take a look. They're going to give us one of those clues here to differentiate. So the symptoms have been gradually worsening for the past 3 months, and the patient is now severely limited in his daily activities. His chest pain is substernal, non-radiating, and non-associated with exertion. Diagnosed with asthma as well as chronic sinusitis 8 years ago. So really try to keep it difficult for us by giving us both asthma and sinusitis. He has been prescribed multiple antibiotics for bacterial sinusitis and prednisone for asthma, but without significant improvement in his symptoms. Also, I wanted to note that EGPA would have kind of like a rash potentially. They may give us palpable purpura with that one. Lately, the patient has noticed weakness and numbness in his lower extremities that increase with exertion, but are also present at rest. So now if I have a pendulum of ABPA versus EGPA, starting to move a little bit more towards EGPA, because of the fact that he's got these like neurologic symptoms now. The patient has no other past medical history and takes no medications, was born in Central America, immigrated to the United States. He has a mild temp, 99.8, not a true fever, blood pressure 118/58, heart rate is 89, O2 sat is 92%, neck veins are flat, cardiopulmonary examination is normal. He's got bilateral wheezing. Neurologic exam reveals 3 out of 5 strength in the right lower extremity and 5 out of 5 strength in the left lower extremity. Okay, so nailed it. This is going to be EGPA. There is also weakness of aversion of the right foot. Left upper extremity also shows decreased grip strength. So this is all a description of mononeuritis multiplex, which is classic for EGPA. A lot of cases, I think a majority of cases of EGPA are going to have mononeuritis multiplex, which is basically when you have neuropathy symptoms in multiple different nerves that are not in an anatomic distribution. So you'll have your left leg and your right arm and your, your finger or something like that. Whereas, diabetes is a polyneuropathy that is symmetric, right? It's length dependent kind of nerves that are getting further and further. So both of your feet start tingling and getting neuropathy, and then both of your fingers or things like that with chemo, for example. So in this case, this is a classic description of mononeuritis multiplex. This is EGPA. 71% of people got this right. Polyneuropathy and mononeuritis multiplex are seen in about 75% of patients. Let's move on to the next one. We might have to actually start a new quiz. I'm at the last question of this quiz. So a 41-year-old woman presents to her internist for a 2-day history of bilateral ear pain and redness. Immediately, what am I thinking of? Bilateral ear pain and redness? I'm not actually sure what's standing out for me there. Looks like we've got some autoimmune markers. Wow, she's got a very interesting ear here. Kind of looks like atrophic. I think might be the way that they would describe this. Like the cartilage has basically been like eroded here. In terms of her labs, her ANA is 1 to 40, which is kind of non-specific. It's pretty low. I'd be more impressed if it was like 1 to 1600 or something like that. Anti-cyclic citrullonated peptide antibodies are 5. So this anti-CCP is kind of associated with rheumatoid arthritis. So could this be rheumatoid arthritis causing something in the ear? I'm trying to make the connection in my brain. ESR is low. Within normal limits, and the rheumatoid factor is low, which is also normal. So rheumatoid factor is actually less specific than anti-CCP. Now I'm also wondering, could it be one of those connective tissue ones like, scleroderma or something like that. So they're asking bronchoscopy, cartilage biopsy, a DEXA scan, methotrexate, or MRI of the brain. So if this is rheumatoid arthritis or some kind of autoimmune connective tissue disease, then methotrexate may be the one disease-modifying therapy that we could choose here. But I'm not actually confident what's going on. So this is her 4th episode in the last 2 years. She denies difficulty walking, fevers, headache, hearing loss, or tinnitus. Symptoms resolved in 2 weeks regardless of topical antibiotics. She has intermittent joint and rib pain that lasts several weeks. Past medical history includes tracheomalacia. So this is definitely starting to give me connective tissue kind of vibes, autoimmune connective tissue disorder vibes. She has had a nose reconstruction 3 years ago. She has lubricating eye drops. First date of her last menstrual period was 2 weeks ago. She is not currently sexually active. Conjunctiva are slightly injected. There's a scar over her nose. Left ear is shown. Everything else is pretty much normal. So the question is, what connective tissue disease is this? Is this mixed connective tissue disease potentially? And is that treated with methotrexate? I'm actually not sure. I don't see what we would be gaining from a DEXA scan, just checking her bone density. I don't see why we would need to check an MRI of her brain. Cartilage biopsy, do we need to have that, or we can just diagnose this clinically? And what would we be doing with the bronchoscopy? So I'm just going to go with methotrexate, but this might be the question that gets us, you guys, because I am not 100% confident on this one. I don't know actually what this diagnosis is. Maybe it's mixed connective tissue disease, and we are finally wrong. So let's add that to our point here. So this is relapsing polychondritis. I do remember learning about that. I believe I have an Anki card on that. So if we take a look at Anki, so relapsing polychondritis can cause a tender trachea and swollen joints. It affects the ear, nose, tracheobronchial tree, and the joints. So this was actually a good question for me to end on because a good one for me to review. So they say that the diagnosis is clinical, so why do we need to do a cartilage biopsy? Some physicians perform a biopsy of the cartilage. Physicians may attempt a trial of empiric dapsone or prednisone, especially in patients who do not respond to NSAIDs. All right, you guys, well, that was quite a run. I'm glad you guys stuck with me because this video went much longer than I was intending because I kept getting questions right, so I just wanted to keep going. But I did want to leave you guys off with one question for you guys to do on your own time. All right, actually, I'm going to skip that one because I was reading through it and it was looking a little bit too simple. So I'm going to skip to this one instead. And it's another hypercalcemia question. So actually, maybe a good spaced review for you guys for one of the questions that we did earlier. So a 50-year-old man presents to the primary care physician's office with fatigue. Physical exam is notable for mild bibasilar crackles on pulmonary auscultation. He appears slightly fatigued, but generally well. Labs are notable for a calcium of 11.5 with an albumin of 3.9, parathyroid hormone of less than 6, a 25-hydroxy vitamin D of 36, and a creatinine of 1.1 milligrams per deciliter. He is taking no medications or supplements. Which of the following is the most appropriate next step? Is it a 125 hydroxy vitamin D level, an angiotensin converting enzyme level, a lactate dehydrogenase level, and an erythrocyte sedimentation rate, prednisone, or zoledronic acid? Leave your answer down below. See what you guys think. See if you guys can all collectively get this answer. And I will see you guys in the next video. Thanks again for watching. Until then, good luck and have fun.